I want you to picture a specific patient. Let's call him David. David has type 2 diabetes. He's had it for maybe 5 years. And he is meticulous, the kind of guy with a spreadsheet for everything.
Mm-hmm.
He pricks his finger every single morning, and for the last 3 months, his home readings, they're pristine. He's averaging about 120, feels great, lost some weight. He walks into his doctor's appointment feeling, victorious.
He's expecting a high five.
Exactly. But then the doctor walks in, looks at the lab report, and just frowns. The HbA1c, the so-called gold standard, is 8.5%.
Yeah.
That's a failing grade.
It's a total gut punch moment. I mean, you have the daily data, the ground truth, as we call it, saying one thing, and the official lab report saying the complete opposite.
It creates this immediate tension. The patient feels like, you're not listening to me, and the doctor's thinking, what is this person hiding?
Right, and in that medical hierarchy, the lab report almost always wins. The assumption is the patient is measuring wrong, or their meter's broken, or they're lying.
But the research we're diving into today suggests a third and much more unsettling option. The pest is lying.
It's a really strong accusation, but the biochemistry, it backs it up. We put an immense amount of trust in that A1C number. I mean, it dictates diagnoses, medications, insurance coverage. Everything. But if you actually look under the hood, specifically at the kinetics of red blood cells, you realize the A1C isn't this simple, objective math problem we treat it as.
And that is our mission for this deep dive. We are unpacking the hidden flaws of hemoglobin A1C. We're going to show that this number isn't just an average of your blood sugar. It is a biological marker that is basically held hostage by the life and death of your red blood cells.
And the variables are huge. From iron deficiency to kidney disease, even your own genetic ancestry can warp this number. And the consequences, they're not academic. People get put on drugs they don't need, or worse, taken off life-saving medication because of a false lab report.
Okay, let's start at the absolute bottom. Explain it like I'm 5. When a doctor orders an A1C, what is chemically happening in that vial? I think most people just assume it's measuring sugar in the liquid part of the blood.
That's a really common misconception. If we just measured sugar in the liquid, that would change minute by minute. What the A1C is actually measuring is the sugar that has physically bonded to the protein inside the red blood cell.
Inside the cell. Okay.
Picture a red blood cell like a little donut floating through your bloodstream. And inside that donut is hemoglobin, the protein that carries oxygen.
Right.
As these little donuts float through your blood, they bump into glucose molecules.
Like a donut bumping into sprinkles.
In a way, yeah. But these sprinkles don't just sit on top. They chemically fuse to the donut. To be technical, the glucose reacts with the N-terminal valine of the beta chain of the hemoglobin. We call it glycation.
N-terminal valine. Okay, that's technical. But the key thing is it's a specific chemical reaction.
Correct. And here is the most important part of all of this. It is an irreversible process.
Irreversible.
Once that hemoglobin is glycated, once the sugar sticks, it stays there for the rest of that cell's life. It's not a Post-it note that falls off. It's a tattoo.
So the A1C is basically just a census, counting how many of your red blood cells have these sugar tattoos.
Exactly. It's a biological record of exposure. And since we assume a red blood cell lives for about 3 months, we use that percentage of tattooed cells to estimate the average sugar level over those 3 months.
But that word average, that seems to be where the first crack in the foundation appears. The common wisdom, even among doctors, is the 3-month average rule. As if a high sugar day 80 days ago matters just as much as yesterday.
That is the intuitive assumption, but kinetic modeling just proves it false. It's not a simple average at all, it's a weighted mean. You have to remember your body is constantly making new cells and destroying old ones.
So the cells circulating right now are younger, on average.
Disproportionately from the recent past, yes. It follows what we call the 50-25-25 distribution rule.
Okay, break that down.
About 50% of your A1C result is determined by the glucose levels of the last 30 days alone.
Wait, half? Just from the last month?
Yes. Half the score is just the last 30 days. The month before that, days 31 to 60, contributes about 25%. And the 3 months ago period, days 61 to 120, that only accounts for the final 25%.
That completely changes how you should interpret the test. If I had a terrible diet 2 months ago but have been perfect for the last 30 days, my A1C is going to look artificially good.
Or the reverse, which happens all the time. You could have been a saint for 2 months, perfect control. But then you get the flu or go on vacation the week before your test, and your A1C will spike disproportionately. It's recency bias, encoded in your blood.
Less of a history book, more of a news feed that highlights recent events.
Yeah.
But this waiting problem seems small compared to what you call the container problem.
Yeah.
We're just assuming these cells live on a set schedule.
This is the elephant in the room. The entire mathematical formula for converting A1C to an average glucose, all of it, is built on the rigid assumption that a human red blood cell lives for exactly 120 days.
And biology is never that rigid.
Never. 120 days is a textbook number. In reality, even in perfectly healthy people, the lifespan is usually around 106 days, and it can swing plus or minus 20, 25 days.
That's a nearly 1 month margin of error on the life of the container itself.
It is. And think about it with a sponge analogy. If you throw a dry sponge into a bucket of water, it soaks it up.
Yeah.
Pull it out after 10 seconds, it's damp. Leave it for 10 minutes, it's saturated.
The red blood cell is the sponge, the sugar is the water.
Precisely. So if your red blood cells just happen to live longer, say 130 or 140 days, they're just floating in that sugar water for longer. They have more time to get tattooed.
So they collect more sugar just by being old, not because the sugar level is actually higher.
Correct. And we call that a false high. Your blood sugar could be perfect, but because your cells are geriatric, they look overloaded with sugar. Your doctor sees a high A1C and ups your medication. But the problem isn't the sugar, it's the cell age.
That is a recipe for hypoglycemia. You're treating a ghost.
Yeah.
And I assume the opposite happens if the cells die young.
Yes, a false low. If your cells turn over really quickly, say they only live 80 days, they just don't have enough time to accumulate that tattoo. You could have dangerously high blood sugar, but because the evidence is being destroyed every 80 days, the A1C looks perfect.
This isn't just theoretical. The notes pointed out some very common conditions. The one that jumped out was iron deficiency anemia, just because of how widespread it is.
It is incredibly common, particularly in women of childbearing age, and it's a classic trap for a false high A1C.
Okay, walk me through that. Why does a lack of iron make the A1C look higher?
Think of it like a production line. Iron is the key raw material the bone marrow needs to make new red blood cells. When you're iron deficient, that production line slows way down. We call it decreased erythropoiesis.
So you're not making enough new baby cells.
Exactly. You're not putting fresh, clean sponges into the bucket. So the average age of the whole population of cells in your bloodstream, it goes up. It becomes a retirement community of red blood cells.
And because they're older.
They're more glycated. There's also some complex biochemistry at play. Evidence suggests a compound called malondialdehyde increases in iron-deficient states, and it might chemically speed up the glycation process itself, so it's a double hit.
Wow. So a patient comes in, she's tired, a little pale. Her A1C is 6.8%, just over the line for diabetes. The doctor says, let's start metformin. But in reality, she might just need an iron pill.
That is exactly what happens. You fix the iron deficiency, the bone marrow kicks back into gear, floods the system with young cells, and the A1C drops back to normal without ever touching the blood sugar. The diabetes disappears because it was never really there.
But that's a false high.
What?
But the false lows, they seem even scarier because they hide the danger. The materials point to kidney disease as maybe the biggest culprit here.
Chronic kidney disease, or CKD. It's the most complex paradox. See, when kidneys fail, they stop producing a hormone called erythropoietin. That's the signal to make new red blood cells.
So they become anemic.
Right. To fix that, we give them these powerful drugs called erythropoietin-stimulating agents, or ESAs. You probably know them as EPO.
Like what athletes use for doping.
The very same. But in a medical setting, it forces the bone marrow to pump out a massive number of new baby red blood cells, or reticulocytes.
So it's the complete opposite of the iron deficiency problem. A flood of new cells.
A huge influx of virgin cells with zero sugar coating. It's like dumping a gallon of fresh water into a small cup of sugary tea. You dilute the concentration instantly. The A1C just plummets.
The case study in the research was mind-blowing. A patient's A1C went from 8.8% down to 4.4% just from starting this drug.
And 4.4% is an incredibly low, healthy, non-diabetic number.
With no change in their actual blood sugar.
Not one bit. The glucose in their blood was still dangerously high,
Yeah.
but the marker, the A1C, had been totally diluted.
That is terrifying. A doctor sees 4.4%, they're going to stop insulin. They'll congratulate the patient, while that high sugar is silently damaging their eyes, their nerves.
It's a case where the gold standard becomes a blindfold. We see similar things with any kind of hemolysis, where cells are destroyed too fast, people on dialysis, for instance. The mechanical stress of the dialysis machine literally smashes red blood cells, shortening their life.
So a dialysis patient will almost always have a falsely low A1C.
Almost always. Relying on an A1C for a dialysis patient it's practically clinical malpractice.
And this same logic of cell turnover applies to our genetics. We have to talk about the Hawaii data because it really challenges this idea that A1C is, racially neutral.
Yes, the Pacific Islander connection, it was fascinating. Hawaii has a very distinct demographic profile. A large portion of the population has Southeast Asian, Filipino, or Pacific Islander heritage.
Right. And in those groups, there's a much higher prevalence of hemoglobinopathies, genetic traits like thalassemia or hemoglobin E.
And those traits actually change the red blood cell itself?
They often result in cells that are smaller or more fragile, so they break down faster. It's a state of mild chronic hemolysis. Faster breakdown means shorter lifespan.
Exactly. The cells die young. So what we see is a systematic lowering of A1C results across these entire populations.
So a standard chart, probably developed on a Caucasian population in Boston, just might not apply to a patient in Honolulu.
That's right. A patient in Hawaii with one of these variants might have an A1C of 7.0%. The guidelines say 7.0 is the target. Great job! But because their cells are dying early, that 7.0 might actually hide an average blood sugar of 180 or 190.
So they're being graded on a curve, but nobody told the doctor.
And it's not a niche issue. We're talking about millions of people globally who carry these traits. Applying a one-size-fits-all metric is guaranteed to miss diagnoses.
Okay, so diet timing, iron levels, kidney drugs, genetics. It feels like the gold standard is actually made of pyrite. If I'm a patient or a clinician listening to this, what's the red flag? When do I stop trusting the number?
The key word you have to look for is discordance, a mismatch. If a patient brings in their glucometer log and the average of their daily finger sticks is 200, but the lab sends back an A1C of 5.5%, do not average them. Do not trust the lab.
Trust the finger stick.
Trust the direct data. The finger stick is measuring glucose directly. The A1C is modeling it through a flawed container. If the map doesn't match the terrain, you trust the terrain.
So if we have to toss the A1C in these cases, what's the alternative? Are there other biomarkers that don't depend on this fickle red blood cell?
There are, and they are tragically underutilized. If the red blood cell is the problem, you have to measure glycation on a different protein, one that is independent of red blood cell survival.
What are our options?
Well, one of the best is fructosamine. Instead of hemoglobin inside a cell, it looks at proteins, mostly albumin floating freely in the blood serum. These proteins turn over much faster, about every 2 to 3 weeks.
So it's a much shorter window, a more recent snapshot.
Right. It's great for seeing if a new treatment is working now instead of waiting 3 months. But the real heavyweight contender, especially in complex cases, is something called glycated albumin, or GA.
Albumin, the main protein in our plasma.
Correct. And it has 2 huge advantages. One, it's not in red blood cells, so anemia, iron, EPO drugs, none of that affects it. 2, it gets sugar-coated about 10 times faster than hemoglobin. It's incredibly sensitive.
So that kidney patient on EPO with the false 4.4% A1C?
Glycated albumin would have told the truth. It would have shown the dangerously high sugar levels. For dialysis patients, GA is just, hands down, it's superior. It correlates much better with actual outcomes.
The notes mentioned one more, 1005 AG. Sounds like a droid from Star Wars.
It does. And 1005 AG is unique. It's the tattletale marker. It detects what we call glycemic excursions.
Excursions, so spikes.
Exactly, spikes. 1005 AG is a substance that your kidneys usually hold on to. They reabsorb it. But if your blood sugar spikes over a certain threshold, around 180, the kidneys get overwhelmed and they just dump the 1005 AG into your urine.
So if my 1005 AG level is low,
it means you've been spiking. It means your average might look okay, but you're having these massive post-meal sugar explosions that are draining your reserves. It catches the volatility that an average just smooths over.
That's incredibly useful. It seems like we have this whole toolkit, fructosamine, GA, 15-AG, but the system is just stuck on the A1C hammer. Is the 3-month A1C checkup going away?
I don't think it should go away entirely. Let's not throw the baby out with the bathwater. For the majority of people with standard biology, no anemia, healthy kidneys, it's cheap, it's standardized, and it does correlate pretty well with long-term complications. It's a good default.
But we have to stop treating it as infallible.
We need to stop being on autopilot. If a patient has kidney disease or is pregnant or is anemic or has a known hemoglobin variant, the standard test is statistically guaranteed to be misleading. In those cases, you have to pivot to what we call ground truth methods.
And ground truth would be
Yeah.
Real-time data.
Exactly. Continuous glucose monitors, CGMs, those little sensors people wear, they measure glucose every 5 minutes. That's 288 data points a day.
Why guess the average age of the crowd when you can just count everyone walking through the door?
Precisely. A CGM gives you the whole movie. An A1C gives you one single blurred photograph from 3 months ago. If you have the movie, you don't need the photo.
This has been a massive reality check. We started with this mystery of why the lab number doesn't match the patient, and we've ended up questioning the very foundation of how we monitor a global disease.
It's a reminder that medicine is biology, not just math. We try so hard to turn the body into a spreadsheet, but the body just refuses to cooperate.
So for the learner listening to this, maybe a patient, maybe a provider, what's the one thing they need to take away from this?
The takeaway is that HbA1c is a tool, not a crystal ball. It relies on a standard body that many, many patients just don't have. If the numbers don't match how you feel or what your daily meter says, believe your body. Investigate the discordance. Ask about iron. Ask about your kidneys. Ask about alternatives like glycated albumin. Don't let a flawed number dictate your health.
And here's a final thought to leave you with. We spend billions of dollars and millions of hours chasing this one number. We treat the number. We medicate the number. But if we're treating the number rather than the unique physiology of the patient sitting in front of us, are we actually practicing medicine? Or are we just doing accounting?
That is the question. In an era of personalized medicine, using a one-size-fits-all biomarker for a disease as complex as diabetes might be the ultimate malpractice. Maybe the future isn't about finding a better average, but about ignoring the average entirely.
Something to chew on before your next checkup. Thanks for diving deep with us.
They're curious.